Welcome to the College Connection podcast, a podcast presented by the College of Registered Nurses of Newfoundland and Labrador. This is the College Connection podcast.
Hello, and welcome to the College Connection podcast, part 2 of our episode, Ask Practice. The College Connection podcast is made available to registered nurses and nurse practitioners to promote good practice and to highlight the importance of regulation in healthcare. My name is Kean, and I am a nursing consultant with policy and practice at the College of Registered Nurses of Newfoundland and Labrador.
Hi, I'm Michelle Carpenter. I'm a registered nurse and the other nursing consultant for policy and practice at the college. So Kelly, today in the part 2, we've received some questions from notes from the practice team when we sent out the call. We received a question about professionalism and specifically related to self-identification, role and name, communication, and appearance. So I guess that all ties in as what is expected as a registered nurse when it comes to professionalism. So what is the regulatory direction on these questions?
Absolutely. Yes, you're right. We do receive this question, relatively common, I guess, especially around introducing yourself with your first name and last name. So it is an expectation is in the entry-level competencies that a registered nurse will introduce themselves with their full name and, their designation and, explain what they're going to do for the client that day. Hello, my name is Kelly Kean. I'm a registered nurse, and I will be providing care for you today. We do receive the question about you giving the full name. It is the regulatory expectation that you disclose the full name. We do recognize, however, that there may be situations, there could be safety concerns in particular environments where that may be an issue. And we encourage registrants then to talk to their manager about those situations. As the general rule, though, you will be using your first name and last name and not covering up your last name on your name tag or putting like a sticker on your picture or like that. Because at the end of the day, the client has a right to know who is providing care for them. And I'm sure some of our listeners, I know most of our listeners are registrants, but they have probably experienced the healthcare system as a client themselves as well. And I think everyone can agree that it's very vulnerable time. So clients are in a very vulnerable position, receiving healthcare, and they have a right to know who is providing that care. If there are any concerns with that care, they need to know the person's name so that they can follow up accordingly. If you're in a busy emergency department, there may be 3 Kellys on that day. So it's very important that they know who is caring for them. So that is the regulatory expectation with respect to first name and last name. Then you asked about communication. And communication, goes right back to our standards of practice. We want to make sure that we are communicating effectively with our clients as well as with our colleagues as well. So we want to make sure that that therapeutic communication is occurring with clients and with our colleagues, because that therapeutic communication is fundamental for the therapeutic nurse-client relationship to build that trust. Without trust, the outcomes of that therapeutic nurse-client relationship, it won't be as positive without that trust at the foundation of that relationship. But again, that's with the client, the therapeutic nurse-client relationship. But the college is receiving, more and more complaints with respect to incivility in the workplace and ineffective communication amongst. It could be a registered nurse. I know we work, of course, with a collaborative team, but it could be amongst each other, could be with another discipline. So it's very important that we are communicating effectively and respectfully respectfully, in the best interest of the client, because clients can feel that tension. So we want to make sure that the communication is effective. And if your colleague is requesting assistance for something, then of course, in the best interest of the client, it is expected that you will collaborate with your colleague, to provide assistance, of course, if it was in your individual competence. So that's the regulatory expectations with respect to communication, but also appearance. Of course, there's employer policy with respect to dress code, and a part of your standard 1, you're expected to follow relevant employer policies. But again, going back to trust, when the client first sees the registered nurse or nurse practitioner, that appearance matters. So, if you enter the room and, you're disheveled, then the trust that they have in you in providing good care may be lessened. It could be disheveled, or you could come in with maybe you don't have your name tag on. You could not be dressed professionally. And not to say that for sure is, means you're not going to deliver safe, competent, and ethical care, but it does play an impact on the amount of trust that the client has in you as the professional. And we recognize as well, people dress as a form of self-expression. If you want to wear, a particular uniform or scrubs, but you have to think about the client. So if you're working in long-term care and you're working with older adults with dementia, and you have a very bright, very busy scrub top or uniform top, that can be a bit of a trigger for someone with dementia to have that type of uniform on. And we recognize, yes, there is that self-expression of the registrant. They should be able to wear what they want to wear. However, when you have that license to practice, you have to remember that everything that you do is in the best interest of the client. It's not in the best interest of yourself. Because that busy, bright, beautiful uniform may be perfectly appropriate in the Janeway, where kids love that, right? So it depends, and you have to think about the client in those when you're making those decisions. The same thing, if again taking the dementia approach, if you're working with you could be on an all male unit, older adults with dementia, and you may have Lululemon leggings on and like a no sleeve tank top. You have to consider the clients that you're caring for with respect to your appearance.
Yeah, no, that's a great answer. So I just want to touch on a couple things, because you talk about introducing yourself with your first and last name and designation, and people, really push back on this question. But I guess I know you and I, when we do education, we inform registrants that first, the client has a right to know who's providing care. But if you choose not to tell the name, or you just give your first name, as you said, it's difficult to identify if there's an issue. But the client can always find out who provided care to them. They can go through that process with medical records and request to read the chart where the registrant will be identified there. So there's never anonymity. The client can find it, and they have a right to know, as you said. So you also talked about like therapeutic nurse-client relationship and your appearance. And I just want to remind the listening audience that we have a lot of relevant college documents on our website under practice resources, practice topics, that talks about professionalism, talks about the therapeutic nurse-client relationship, that talks about social media, all of those that is the essence of what it means under standard 3.1 demonstrates a professional presence and models professional behavior. So it gives you a little bit more information or outlines the practice expectations. And again, registrants can reach out to you and I if they have any questions. And this tends to be a popular presentation that we do with registrants. So thank you for that.
And you just jogged my memory then too, Michelle, when you talked about, the client can find out who provided care, because we often get the pushback related to social media. So if the client is aware of your first name and last name, they can write poor things about you on social media and tag you in those things. That is a possibility. We encourage registrants to, have your privacy settings such that, that can't happen. But also, in the event anything like that ever happened, and this going back to our documents that you were referring to, we do have one on social media under those professionalism. To never respond to anything that is written like that on social media, and to talk to your manager, because there are ways that employers can have that removed. And the minute that you acknowledge that post, comment on it in any way, then that's a breach of privacy and confidentiality. And I don't think that all registrants, that's at the top of the mind. Yes. Of course, when you see something like that, of course, you're going to feel angry and you want to defend yourself. But we definitely recommend to not engage and talk to your manager about getting that removed.
Absolutely. So, and again, any questions, they can certainly reach out to us. Absolutely.
Absolutely. So, Michelle, I have a question for you. We had a registrant reached out, and this person asks, my employer does not require me to have a license as a registered nurse. Can I claim my position as practice hours as a registered nurse?
Well, the answer to that is it all depends. So we've been seeing, over the past number of years, particularly since COVID, that RNs and NPs are moving out into different practice settings and a wide variety. And there are times when the employer doesn't require you to do, RN or NP practice, or requires you to be an RN to hold that license to practice. So, but on assessment and reflection, the RN and NP says, but I'm using my nursing knowledge and I'm using the nursing process in that position. So can I use those hours? So what we've created, and you can find this non-traditional attestation, role attestation form. It's on under practice resources, practice topics, under scope of practice framework. Called there is, as I said, the non-attestation role form, and it basically asks you a number of questions. So it's saying that if your employer doesn't require you to be a registered nurse or nurse practitioner, if you're using nursing theories and the humanities, and you're using the nursing process, the employer allows you to hold yourself out as a registered nurse, to identify yourself as a registered nurse, to sign your credentials as a registered nurse. And there's a number of other questions on that checklist that you would need to answer yes to. Then we would then ask you to submit that to the college. You and I, we process those forms, and we reflect on what the practitioner has sent to us. So we don't approve your position. What we approve, if you've answered yes to all of those questions, what we're saying is you're saying that you meet the definition of practice as a registered nurse or nurse practitioner. But where do we find that definition? Well, we actually find it in the scope of practice framework document, which is located just above that non-traditional role attestation form on our website. And you can go there to find out what that definition is, what is defined as the practice of a registered nurse or practice as a nurse practitioner. So what happens is you are attesting that you meet all of those requirements to say that my practice is a registered nurse when I'm in this role. And so we will recognize that, and we then process it and send it on to registration. And they put it on your file because when you go to renew your license, it's now self-reporting. You would report your hours in that position. It's not the employer anymore. It's you as a registered nurse. And you would say that I'm working in this role because you've dated your identity profile to say this is where you're working, and those hours will be recognized as practice as a registered nurse. But there may be circumstances where you're in a role as a registered nurse. It didn't require you to be a registered nurse, but the role may be more like an administrative role, and you're not really using the nursing knowledge and all of those, theories and that we learned and the nursing process. So when you're looking at those questions on the checklist, you may not meet all of those requirements. So then we probably would not be able to recognize it. But again, any questions, they can reach out to us. Now, a lot of times we get a little bit of confusion in that checklist because it says, do your employer, number 3, I think is the question, it says, do your employer require you to be a registered nurse? And I said you had to answer yes to all of those. We would say no, you answer no to that one, but we'll accept it because we expect you to say no, right? Because that's why you're filling out the non-attestation role a form, because if your employer requires you to be a registered nurse, then you don't need to do out a form, right? And then you would just self-report your hours. The only time anyone else has to submit a checklist is if you're employed in contract or self-employment. And it's very similar. The questions are very similar, but we're then self-employed is in our scope of practice document. When you're going into contract or self-employment, you have to contact the college. And so that is the checklist that you have to fill out.
Absolutely. And we recognize that nursing occurs across many domains, clinical practice, research, administration, education, and policy. Because I heard you did mention the administration one there, but so we'll have to have a conversation with the registrants should they answer no. Absolutely. And
Could I clarify that? Because when I said
absolutely.
administration, what I meant was like you could be doing like HR things or clerical things when I meant administrative there. So it's clerical things, which wouldn't be relying on the nursing knowledge, right? Your nursing theories and the nursing process. So that probably wouldn't, count. But again, just reach out to us and we can assist you on that.
Yeah. And for registrants too, because we see it sometimes where they've been working somewhere and they haven't had a nursing license, but now they're like, ooh, on second thought, I am using the nursing knowledge. And now they want to they want to work in the same job, and now they want a license to practice. But it's but then they, if we recognize that as practice hours, then there's that unauthorized practice that may have been occurring. So it's a bit complicated, and we encourage all registrants to reach out and have that discussion.
Yeah. So reach out before you get into that employment setting. The key is, because we don't want to, go down that scenario where you've already started. If you're thinking about or you've had a job offer, reach out to us, and then we can help assist you with that. So
and we do have lots of registrants that reach out early, and that is the best thing.
So Kelly, we received another question, and it says, I'm finding that I'm having difficulty sleeping at night and concentrating at work. I feel like I'm getting more anxious and sweating before I have to speak to the nurse practitioner or the family of the client. And I'm also snapping at my colleagues. What should I do?
Yes, so that question, that really highlights fitness to practice. And I'm sure registrants have heard of that phrase before. That comes right from our standards of practice for registered nurses and nurse practitioners, standard 1, and it's 1.5, where the RN and NP accepts accountability and takes action to ensure fitness to practice. Because when you have a license to practice, when you go in, report to your shift, or when you're out there in your practice setting, the public expects safe, competent, and ethical care. So you have to be in a position where you deliver that. Yep. And what sometimes we see is that registrants sometimes don't they aren't aware that they weren't fit to practice. You may be experiencing, exactly like this registrant said, those physiological symptoms of stress. And so it's very important that registrants reflect on their nursing is a reflective practice.
Absolutely.
But it's very important that you reflect on your ability to practice safely, and before it gets to a point where there is conduct deserving of sanction, where you may have an allegation filed against you, you have to take steps to to improve that fitness to practice. It doesn't necessarily mean you can't work at all, but it's about finding those resources. So, I know through the employer, through Newfoundland Labrador Health Services, they have the Employee Family Assistance Program. And, there could be counseling session, or you may go through private insurance or what have you to go through some of those counseling sessions. It may be, that you take steps after your shift or days that you're off, that you engage in some physical activity that helps with stress levels. Or, you may have to talk to your primary healthcare provider, related to how to manage your stress, whether that be pharmacology or non-pharmacological interventions. But it's your responsibility as a registered nurse and nurse practitioner to take steps to ensure fitness to practice.
Yeah, great. So, because even when we talk to registrants, when we're doing presentations, or even to nursing students, when we talk about it, it's too late when something goes wrong, right?
Absolutely.
When conduct has gone into conduct is serving a sanction. So it's the RNs or NPs' responsibility and accountability to recognize that you're having those, mental, physical, psychological issues, and if you recognize, and you're responsible to recognize that you're experiencing all of these symptoms, that you take action, right? And it's very uncommon, but have been circumstances where people have been suffering from mental health or addictions, and they've called the college and have changed to a non-practicing membership while they're trying to get help and have resources to get them back on track. Because, as you said, the public is expecting safe, competent, compassionate, and ethical practitioners. And if we're not fit, if we're not able to carry out the duties and the responsibilities of a professional registered nurse or nurse practitioner, then we have that responsibility to withdraw from our care, and we can't just walk off the unit and abandon. We got to have those conversations with our manager and seek those resources. But it's your responsibility to stop, reflect, and say, is this in the best interest of my client to come to work in this? So we're not telling everyone to call in sick. We're not telling, rest assured, we're not saying that, but we're saying it's your responsibility to recognize that.
Absolutely, Michelle. That's a good point with respect to fitness to practice, because like you said, it's too late once something happens and there's a breach in those standards. So it's all about recognizing, and nobody can tell you. So, I mean, sometimes there's objective evidence when someone's not fit to practice.
Yeah.
But because we get the question sometimes, I just worked 12 hours and now my manager asked me to stay on for another 8. We can't say, well, you're not fit to practice, so you can't be mandated. That's not something that the regulator can say. You have to reflect on your own fitness to practice. And in those situations, we recognize the healthcare shortages. So if you are mandated to, you get mandated overtime, then have those conversations with your manager. Let's say that you are, assigned, you're let's say if you work in long-term care,
Yeah.
and maybe someone else can do the medication administration if that's
Absolutely.
something that you were assigned to, or perhaps you can have a little bit of an extended break as long as you talk to your manager about that. Exactly like you said, you can't just walk off the unit and not have appropriate conversations with your employer about these things, and you're just gone for 3 hours and no one really knows where you are.
Yes.
It's about having those conversations, because perhaps something can be arranged where that, yeah, you know what, we can get coverage for you to take that little bit of an extended break to make sure that you are able to provide that safe care.
Right.
Good. Okay, so another question about RN prescribing. So we're seeing a few RN prescribers now in Newfoundland and Labrador, but we are getting a lot of inquiries about that. So if someone is interested in becoming an RN prescriber, how do they go about that?
Great question. And, currently the legislation has been in place since April 3rd, I think it was, in 2023, when government, passed amendments to the RN regulations to permit RN prescribing. So first of all, I would encourage registered nurses to read our resources on our website. So we have a practice topic called RN prescribing, and it lays out the requirements. We have the RN prescribing framework, the RN prescribing practice guidelines, and there's some FAQs, frequently asked questions, for registered nurses to review. So I would get knowledgeable on what is expected. And then it goes back to the registered nurse having that conversation with their manager, because you have to have an employer sponsor, meaning your employer must agree that there's a recognized need in your specific practice setting. So it's having that conversation with your manager to determine if an RN prescriber role is appropriate for the practice setting. And generally what we've said, like an RN will be able to prescribe for like a specific condition. It may be clients who are suffering with diabetes. It could be clients who have issues and require wound care. It could be different populations. It could be clients with congestive heart failure. We have also regional nurses in Labrador zone that dispense medications and use the First Nations Inuit Health Board guidelines to dispense medications and provide care in remote and isolated communities. And now, to have that independence, they are moving into becoming authorized to be RN prescribers. But a requirement as well is that the RN has to work within a collaborative team. So, so within that collaborative team, it's a couple of reasons why we need that. One is the RN will be relying on that collaborative team and an authorized prescriber to reach out if they have to consult on something, or if something's outside of their their scope of practice, then they may need to consult with an authorized prescriber, or they may have to transfer the care. But also, it's RNs will prescribe using a clinical decision tool. So that's very, I guess, it's prescriptive in what the prescribing of pharmacological or non-pharmacological interventions or medications, laboratory and diagnostic tests has to be identified in that clinical decision tool. Now, in Newfoundland, we've decided to call it a guidance document. So that guidance document must be developed within that collaborative team to identify what the RN is permitted to prescribe or order and what they are not. So, that collaborative team collaborate to develop that clinical decision tool. So I guess the first step is identifying with your manager that there's this need, but then the RN, because RN prescribing is not part of the entry-level competencies that were taught in the entry to practice nursing program, the Bachelor of Science of Nursing, then they will have to get that continuing education, right? They have to get that theory and practical through continuing education. So we have identified the 3 courses. So council approved, our college council approved the 3 courses that would be required. And they're now being offered through Saskatchewan Polytechnic. It's a university in Saskatchewan, and these are listed on our website. They are assessment and clinical reasoning, rational drug therapy for RN prescribers, and then clinical decision making for RN prescribers. So this is your preceptorship. So RNs may take from 80 to 160 hours to facilitate and to, bring all of that knowledge that they've learned in the first 2 courses into that clinical practice where they're in their practice setting and, refining those, the knowledge that they've gained into practice. And they're working with a preceptor who's an authorized prescriber to facilitate that amalgamation of all of that prescribing behaviors that they need to learn. So then after they've successfully completed those 3 courses and they're self-paced, there's an application process. And I'll go back to there are a cost to these courses, and that's all information's all on our website about that. But there may be funding within your organization, so I would encourage you to reach out to your employer to see if there's any funding for you. If not, will be a cost for each of those, and they're about $1,500 for the 3 of them in total. So when you complete those courses, then there's an application process, and yourself and the manager is attesting that you have these things in place. So there should be a practice guideline or a policy that outlines your expectation as a RN prescriber. And then there is an attestation saying that you have a guidance document, that all of the expectations for you to prescribe, for example, for wound care, is all laid out. What medications you can prescribe, what laboratory and diagnostic tests, and in RN prescribing, the government has also authorized RNs to make referrals to specialists, to other healthcare practitioners. So they will determine in those clinical practice, the clinical decision tool or guidance document, who you would refer to based on the population that you're providing. So that is there. So the application process is there. We encourage RNs to reach out to us before they do the application process so we can talk through what those practice expectations are, because this is all very new. And the manager and yourself are also attesting that you work within a collaborative team, and that those processes are in place if you require that reaching out for collaboration or for transfer for those things outside of your scope.
And I guess that's why, Michelle, sorry, and I guess that's why it's not permitted in self-employment.
Yeah. Absolutely.
It's the collaborative team
piece.
It's
the collaborative team. And so this is all very new. It's like when nurse practitioners were first introduced to Newfoundland, the ability to prescribe and order tests was very prescriptive. Yes. And it was laid out what they could do. The college has decided with government that we're not going to do lists. The college is not going to do that list. Who knows the population better than the employer? They will develop those guidance documents based on best practice, evidence-informed knowledge, skills, and judgment for what is required for their populations. But it's really important that guidance document is in place, and in the appendix, in the prescribing framework, it lays out what should be in your guidance document for the registered nurse prescriber. So that application is then submitted to us when all of that is there, and with the copies of the certificates of completion of the courses. And then if all things are in place, that goes to registration. And the college then grants you authority to prescribe, and that will go on our member search in our Lindy member portal that would be uploaded. And on our member search, if someone went in and looked you as a registered nurse up, they would see under specialization that you are you have prescribing authority. So that's, notice to the public, because this is open to the public to say, yep, Michelle Carpenter, she has the authority to prescribe. And you'll see that specialization icon there. You click on that and you'll see it.
Perfect. And yeah, and going back to, the college has put some limitations
Yes.
Around RN prescribing because it's so new. And
Yes.
of course, with anything new, you need to evaluate.
Yes.
So, working towards getting an evaluation done of RN prescribing to see to make those continuous
Yes.
process improvements. And, what we say today may not be what it looks like a year or 2 years from now. And who knows, in 5 years, maybe it might be a part of the ELCs,
Absolutely.
right? The RN ELCs. But what I'm hearing from you about RN prescribing, very different from a nurse practitioner.
Absolutely.
Very, very different. Yeah.
Yeah.
So, I mean, yes.
Yeah. So NPs are autonomous prescribers.
Yeah.
RNs are not, right?
Right.
They prescribe according to a clinical decision tool. And I guess another thing to consider in RN prescribing, Kelly, and we talk about the limitations, and I'll talk about that in a second, is that the employer, as I said at the beginning, will determine, is it appropriate for you to become an RN prescriber for that practice setting. So that RN, the college has not specified. In other jurisdictions, they've specified that an RN has to work in this particular setting for like 3,000 hours or 4,600 hours. We have not done that because the employer knows best who is experienced in that practice setting, right? So you have to have a minimum amount of experience in that practice setting. So for that very reason, one of the limitations is that there's no portability, because to become an RN prescriber, you're pulling on your knowledge of that specific population or unit that you're working in. And so the tests, your client care needs, the tests that are ordered, what the best practices are for, and the medications that are prescribed for those clients. So you're building on that RN knowledge to become a prescriber. So what we're saying right now, because this is so new, there's no portability. Now, that's not to say if you're working in diabetes education in Labrador zone and you move to St. John's to Eastern zone urban, that you cannot bring that prescribing authority. You are required to call the college. Mm-hmm. And if the clinical decision tool, the guidance document is the same, because we're NLHS is all amalgamated now, is all merged, they may have the same document. Then we would consider that. But right now, if you're working in urology and you become an RN prescriber, to transfer over to general surgery, that's not permitted. But as you said, as we do the evaluation, because we only have 5 RN prescribers right now, but as we authorize more, we're going to be doing an evaluation of the RN prescribers, the key partners, to determine how we can, eliminate some of those limitations and to allow it with less restrictions. Another restriction that we have, or limitation, I should say, is that we're not permitting controlled drugs and substances right now, because there's a higher risk. Yes. But again, that could change. We also say that RNs can't prescribe medications that are like in protocols, study protocols. You can't give out drug samples because that's in legislation that you can't. So it's all laid out in that prescribing framework. And if RNs have questions about that, they can certainly reach out to us. But there is rationale why. We put those limitations in place. But we're going to be putting some quality improvements, process improvements in place to allow RN prescribing to expand in the future. So it's a process, it's a phased-in approach, but I'm sure stay tuned, and as we learn more, we'll do that.
Absolutely. One final question, Michelle, okay. And we get it every fall. It's related to vaccines. So we had a question from a registrant. They said that they have an opportunity this fall to administer flu and COVID vaccines with a community pharmacy. what does that person need to consider before they begin this role?
Well, I think it's a couple things, Kelly. Thanks for the question. And we, as you said, we get this question all along. First of all, I think there's two things that an RN has to reflect on. And one is, do you have the individual competence to, and it goes back to scope of practice framework. Are you educated? Are you authorized? And are you competent? But do you have the necessary knowledge, skills, and judgment to do and provide vaccines? There's also government requirements, and they have an immunization policy that permits, under a medical or care directive, for RNs and for RNs to provide, vaccines under this medical directive in the healthcare system. But when you go into community, it's different. There isn't a care directive. And then we, tied into that is that you have to look at the drug schedules. So where is a vaccine? Is it a Schedule 1 that requires an order from an authorized prescriber, or is it it doesn't require? Is it a Schedule 2? And vaccines, for the ones that we talk about and get the questions about, flu, COVID, and RSV are the three main ones. They don't require an order. But as a registered nurse who is not an RN prescriber, any intervention or medication or vaccine that they're giving, they require authorization, right? It's going back to that scope framework. And so the authorization for an RN in a pharmacy environment would have to come from the pharmacists, right? And they are authorized to order, but they have limitations. But they're able to authorize an RN to give vaccines based on the drug schedules in that community pharmacy. So we have a fact sheet, frequently asked questions on our website under immunizations, under practice topics that an RN would refer to. So in that pharmacy, the pharmacist would have to create a collaborative policy with the RN for giving vaccines. So first, as I said, the RN would need to have that individual competence. If they don't, there is education through the Department of Health Community Services that they can avail of to get that competence. So in that policy, it would have to lay out what is age groups that they can give, what are the doses of the vaccines that they would give for pediatric or adult, but also how to manage the outcomes. So if there's anaphylactic reaction, what does the RN do? So in, from talking to the pharmacists and to RNs, under the drug schedules, a pharmacist is not permitted to order epinephrine, but they can order the auto-inject. So then the pharmacist can lay out in their policy that should there be anaphylaxis, the RN is permitted to provide the auto-inject, whatever dose for adult and pediatric. So all of that is laid out, the expectations for the pharmacist and the expectations for the RNs. But also a part of care, we'll go back to our previous episode from Ask the Practice about documentation, and an RN has to be able to document the care that they provide. So where does the RN document? They're not permitted to document on pharmacy forms. So the pharmacist would have to have the necessary documentation forms for the vaccines. And my understanding, there's forms from the Department of Health Community Services that you would use for documenting that you gave the flu. But there, if there's progress notes or anything that needs to be documented, it would have to be a nursing specific. And also, as I said, that policy is going to be the key to providing this care. So that FAQ is invaluable for the RN to consider. And again, I always say they can reach out to us if they have any questions.
Absolutely. That's excellent. Thank you, Michelle, for that. It was a very detailed answer. So that concludes part 2 of our episode, Ask Practice. Stay tuned for part 3, where Michelle and I will be asking each other some more questions that we have received from registrants. Take care, everybody.
This has been a presentation of the College of Registered Nurses of Newfoundland and Labrador.